Hi everyone, I'm Flavia Matovu Chiwewa from Makerere University in Uganda. We hereby provide you with the first review on bone health and HIV in resource-limited settings. Sub-Saharan Africa and other resource-limited settings continue to bear the greatest burden of the HIV epidemic globally. 70% of the 38 million people currently living with HIV are in Sub-Saharan Africa. Fortunately, the expanding access to highly active antiretroviral therapy has led to increased life expectancy of HIV-infected individuals in the last 2 decades, and newer treatment options like tenofovir-based ARVs with simpler once-a-day dosing regimens promise even further increases in survival. On the downside, some of these HIV medications, and of greatest concern tenofovir, have been associated with metabolic bone complications. On treatment initiation, there is a small but significant amount of bone loss that occurs more rapidly in the first 1 year of use, and this does not return to baseline levels following virologic suppression. The normal bone growth trajectory is such that as one grows up, you accrue your bone mass, which peaks at around the age of 19 to 25, maximum 30. By the age of 35, you slowly start to lose bone. In the setting of HIV and its treatment, this aging process is going to occur much earlier and more rapidly, leading to a reduction in bone mass and strength, what we call osteopenia, or in severe forms osteoporosis. And this exposes HIV-infected individuals to increased risk of fragility fractures, either short-term or later on in life. Therefore, as more HIV-infected individuals access ARVs and live longer with HIV more than ever before, these HIV treatment-related complications are expected to increase. Findings from resource-rich settings where the topic of bone health has been extensively studied show that 2 out of every 3 HIV-infected individuals have low bone mineral density, with those on ART at greater risk. And again, data from the same settings shows increased fracture risk, with fracture rates of about 30 to 70% higher among HIV-infected individuals compared to HIV-negative controls, regardless of age. We therefore set out to conduct a review of recently published and presented data on bone health and HIV in resource-limited settings, paying special attention to women whose choice of contraception, like Depo-Provera, further compromises their bone health, as well as HIV perinatally infected adolescents who have the greatest cumulative lifetime exposure to HIV and its treatment. And this is what we found. First, we found very few studies on bone health and HIV in resource-limited settings, majority of which were cross-sectional in design and lacked appropriate local reference data. This could partly be due to lack of proper diagnostic tools like the DEXA scan, which is the standard tool for measuring bone mineral density. Secondly, we found a generally higher prevalence of low bone mineral density in resource-limited settings compared to resource-rich settings, and a high but similar proportion of low vitamin D in both resource-rich and resource-limited settings. Our review also highlights important gaps in our knowledge about HIV and bone health in resource-limited settings. First of all, despite widespread use of tenofovir for HIV treatment in resource-limited settings, there are no published data on the effect of tenofovir initiation on bone mineral density in our settings. Secondly, there are no data on bone mineral density among HIV-infected women on Depo-Provera for contraception. And again, there are no data on bone mineral density among HIV perinatally infected adolescents. And very concerning, there are no data on HIV and fracture risk in resource-limited settings. Given these critical gaps in knowledge about HIV and bone health in resource-limited settings, there are currently no policy and clinical care guidelines on minimizing bone loss for HIV-infected individuals, which creates an urgent need for targeted research that can inform HIV care and management guidelines in resource-limited settings. And to address these gaps, we describe potential research and capacity development priorities for the future of bone health in resource-limited settings, which we believe can be achieved through existing regional and global research networks. Enjoy reading the full review paper in the May 2016 issue of the Current Opinion and HIV/AIDS Journal. On behalf of all co-authors, thank you.